Good morning or good afternoon, everybody, depending where you are in the world. Welcome. My name is Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome to today's public health conversation. Some thank yous before we begin. Thank you to our event co-host, the Society for Epidemiologic Research. Thank you to our epidemiology department for their leadership in putting this event together. Special thanks to the department chair, Professor Martha Werler, and then to Meredith Brown and Alicia Noel, who make these events happen. And thank you to all of you who joined us yesterday for part one of this public health conversation. We host these public health conversations with the aim of discussing the foundational issues that shape health, with the aim of exchanging ideas and of learning from distinguished guests. This year, these conversations intersect with our school's 45th anniversary. To mark this anniversary, we have chosen to elevate the theme, Public Health, Now is the Time. Each month, we have focused on a different feature of public health. This month, we are foregrounding epidemiology. Epidemiology, the study of disease in populations, is at the heart of public health. During the pandemic, epidemiology has been central to our response to COVID-19. As we have engaged with a novel pathogen, epidemiology has guided much of that focus, as have events of the past year. The killing of George Floyd last May sparked an ongoing, long overdue conversation about how race shapes health in the United States. Yesterday, at part one of this conversation, we discussed the history of census data, how data on race are collected and studied, and the implications of how these data are used in population health science. At this session, we will focus on the influence of epidemiology has had on closing race-related health gaps. We will then reconvene at 12:30 this afternoon for our third and final session. It's now my great privilege to turn the screen over to Professor Magdalena Cerda. Magda is a friend, a colleague, associate professor in Department of Population Health at NYU Langone Health, as well as moderator of today's event. Professor Cerda, over to you.
Thank you very much, Dr. Galea. I'm very excited to be moderating this really fascinating panel. So I'm going to start off by introducing the series of speakers, and after that, we're going to move on to the presentations. I'd ask anyone who has questions to put them on the chat, and after the end of the presentation and some moderated discussion, I will be reading off the questions for the panelists. So to introduce the panelists, first we're going to hear from Dr. Amani Allen. Dr. Allen is the Executive Associate Dean and Professor of Community Health Sciences and Epidemiology at the University of California at Berkeley. And her research focuses on race and socioeconomic disparities in health and how we measure and study racism as a social determinant of health. Next, we will turn to Dr. Amuta Onukaga, who's an associate professor of public health and community medicine at the Tufts University School of Medicine. Her current research interests include health disparities, reproductive health, infant mortality, and HIV/AIDS in ethnic minority populations. And she has experience as a researcher in community-based settings in a variety of areas. Third, we will hear from Dr. Danya Young, who is an assistant professor with joint faculty appointments in the College of Pharmacy and Public Health at Ohio State University. At OSU, Dr. Danya Young's research goal is to help improve the health of racial and ethnic minorities by generating information to improve adherence, safety, and effectiveness of prescribed medications.
Magda, sorry, I don't mean to interrupt, I apologize. There's a lot of noise. I think it might be papers on your computer close to your microphone. We're getting a lot of comments from the panelists. I apologize. I just, because people have been chatting. Thank you.
Thank you. Thank you, and apologies for that. So after hearing from Dr. Donna Young, we're going to turn to Dr. Graves, who's a professor of biological sciences at the Joint School of Nanosciences and Nanoengineering at North Carolina A&T State University and UNC Greensboro. Dr. Graves leads programs addressing underrepresentation of minorities in science and aids underserved youth in Greensboro through the YMCA Chess program. He has also served on the Racial Reconciliation and Justice Commission of the Episcopal Diocese of North Carolina. Finally, we will hear from Dr. Ocampo. Dr. Ocampo is the acting Vice President of Research at St. Michael's Hospital in Toronto and the acting Executive Director of the Li Ka-shing Knowledge Institute at SMH. She's a professor of the Dalla Lana School of Public Health Sciences at the University of Toronto. Dr. Ocampo is an internationally renowned public health researcher who has an active research program that focuses on understanding the health impacts of complex urban problems experienced by low-income populations. This is just a stellar group of speakers that we are very fortunate to hear from today. Thank you everybody for joining us, and thank you to the speakers for taking the time to talk with us today. So over to you, Dr. Allen. Thank you.
Okay, I had to find my unmute button. Can everyone see the slide okay? Okay, perfect. Well, let me start by saying thank you to Dean Galea, SER, Meredith Brown, and the entire BU SPH family for having me as part of this very important series on epidemiology and race. The question we were asked to consider is, has epidemiology made a difference in race-related health disparities? To begin, I will describe what I see as three of the most important contributions the field has made in improving understanding of the origins of racial health disparities. First is unit of analysis. John Castle, Mervyn Susser, Jeffrey Rose, A.J. McMichael, and other more contemporary scholars popularized this notion of going beyond the level of the individual to consider population-level exposures and the social context in which health is produced or obstructed. Discussions during the epi wars about the strengths and limitations of molecular epi, black box epi, and the social determinants of health, which we now call social epi, ultimately gave way to a more holistic perspective of the multi-level determinants of health. This, of course, was important in shifting ontological notions of what race is and who and what is responsible for racial health disparities. And these philosophical discussions and advancements helped us move from blaming individuals and from a reductionist, essentialist, and biological definition or perspective of race to a fuller understanding of the production of inequality. This is germane to our understanding of racial health disparities, given that race is a primary source of social stratification in the United States. The second contribution I'd like to mention is theory related to the production of racial health disparities in particular. Overall, epi as a discipline has been deficient in this area, which I will talk more about later, but there have been some tremendous contributions that have been essential to perhaps the most fundamental aspect of our investigations, our questions. In the year of his death, Castle stated in his seminal work on the social environment and host resistance, quote, "Epidemiology is something more than the total of its established facts. It includes their orderly arrangement into chains of inference, which extend beyond the bounds of direct observation." He continued, "It is this orderly arrangement into chains of inference which intrigues me and which I think distinguishes creative epidemiologic studies from studies which may display considerable rigor in their methods, but which are essentially pedestrian. What guides us in developing these chains of inference," he argues, "is the model of disease causation we espouse." In his work, for example, Castle talked about the role of the social environment to changes in human resistance resulting in disease, noting, however, that the specific clinical manifestation of this physiologic disturbance may vary. And we can link this idea of non-specific disease etiology and physiologic stress emanating from changes in the social milieu to the pervasive health disparities we see by race. Across numerous outcomes, we see very predictable patterns of racial health disparities. Castle proposed that the social environment places some groups at greater risk due to the strain placed on physiologic systems in order to adapt to environmental stress. So theory is essential because it helps us frame our questions and pose hypotheses about causal pathways. It influences both the site of etiologic action as well as the site of intervention, moving us toward a discussion of the types of interventions required to not just shift the population mean, but to also bring in the tail of the distribution. So what is the model of disease causation we espouse? Krieger's theoretical work on eco-social theory has been critical in moving the field toward a greater understanding of the multi-level and social causation of disease, which is especially relevant in thinking about racial health disparities. In much the same way, Rose, Frolick and Potvin, Bruce Link and Joe Phelan and others have been essential to being more critical of what we mean when we talk about a population approach, recognizing that the causes of population health are not the same as the causes of health disparities. So when we blindly and uncritically endorse a population health perspective, we may very well miss the most important public health contribution we can make. That is, I would argue, reducing health disparities. Importantly, when we think about the groups most at risk and consider a population approach, the distribution to speak of is not necessarily the distribution of health outcomes, but rather the distribution of social risk, what Lincoln Phelan called risk of risks, and what Tom Glass called risk regulators. So moving the needle on racial health disparities requires not just acknowledging racial health disparities, but acknowledging why and how racial disparities exist and have persisted over time. That requires a different kind of question, not just a surveillance question documenting the existence of disparities, but a question of the factors driving those disparities, a question of the distribution of the social determinants of health, and then how that distribution impacts racial health disparities. For that, we must change the X's, our explanatory variables. So theory has helped us in thinking about how to frame not just the causes of states of ill-being, but the causes of disparities in states of ill-being. Those are fundamentally different questions. It's a question of epistemology, which is something we don't talk enough about in modern epidemiology. In addition to Susster's eco-epidemiology, Krieger's eco-social theory, Lincoln Phelan's fundamental cause theory, Rose and others' discussions about individual versus population health and population health versus health disparities, other theoretical contributions include discussions about race as a cause, articulation of racism as an exposure, moving beyond race as a control variable, moving beyond the race or SES debate to an appreciation of the ways in which race and SES intersect to produce health risk or health protection. Moving beyond surveillance studies that simply document racial health disparities without asking why or how. Weathering and other theories of the embodiment of social inequality. And John Henryism as an example of gendered racism and other theories that bring a more intersectional lens. All of these are essential to framing the question and directing our study designs. The third contribution of the field that has improved understanding of the origins of racial health disparities is the questions we ask. This is, of course, in large part due to the theoretical contributions and debates that have ensued over the past many years, but is worthy of its own attention. In previous work, I've talked about the way race and racial health disparities are interrogated in epidemiology. First, surveillance questions, i.e. documentation of health disparities by race, which is useful as long as we call it what it is. Second, race as a control variable, thus explaining away racial differences in the exposure and outcome of interest. Kamara Jones's writing has been incredibly influential in this regard. Third, race as an exposure, which is either tantamount to surveillance at best, or at worst, to the uncritical use of race as a proxy for innumerable exposures, leaving the interpretation of study findings to one's imagination with inherent biases depending on one's ontological views and interpretive frameworks. And there's a fourth category in social epidemiology, considering the causal pathways, articulating particular causal mechanisms and measuring that rather than using race as a catch-all proxy. Contributions here include furthering our understanding of racism, place, and socioeconomic position as social determinants of racial health disparities, factors which are not, by the way, mutually exclusive. Next, for the sake of time, I will just mention 3 challenges that I believe have impeded our ability to have greater impact. First is our lack of attention to the measurement of social determinants, which results in misestimation of the contribution of various factors on racial health disparities, which is essential to our understanding of how to intervene to mitigate risk. With few exceptions, such as Krieger, David Williams, Braveman, and others, Epi as a discipline has not done very much on the measurement or psychometric analysis of the constructs we purport to capture in our work. This includes the uncritical use of socioeconomic indicators, the incommensurability of socioeconomic indicators across racial groups, and the incommensurability of measures of racism across groups, disrupting the integrity of our racial comparisons. What are the social experiences we wish to capture, and how do we measure those experiences or conditions in a way that reduces measurement error as much as possible in order to maximize the internal validity of our work? And qualitative research is extremely helpful in this regard. Second, despite some movement beyond the use of race as a control variable, the majority of studies published in AJE, for example, that include race still use race as a control variable. This practice has actually increased over time and has been coupled by a decline in the percent of studies indicating their rationale for the inclusion of race, which results in atheoretical and uncritical use of race as a variable in epidemiologic research. This is a structural issue. If we as a discipline allow it, it will continue despite the fact that we know better. There is a role for our journals to play. They are the gatekeepers of what exists as scientific evidence and what doesn't. And I'm not picking on AJE, this is for all epi journals. One of the principles of ecosocial theory is accountability and agency. To what extent do we hold ourselves and our discipline accountable for doing better? It's kind of like how we say in church, if we know better, we're expected to do better. And certainly we know better. Third and last is theory. Although there have been important theoretical contributions, more work is needed. In her 2014 contribution to the Vanderweel and Robinson point counterpoint, Krieger wrote, quote, "In any science, the causal theories it employs are key to its definition and practices. Methods, however vital for testing hypotheses, cannot by themselves define a scientific discipline." And McMichael questioned, quote, "Has epidemiology become predominantly a discipline of technique rather than of substantive understanding? These are important questions to consider. What practices and norms are in place in our epi programs to engender an appreciation for the role of theory so that we are doing more than graduating methodologists? It shouldn't come down to who you happen to have as a mentor. Structures need to be put in place to make theoretical development a critical aspect of any graduate program in epidemiology. Methods, after all, follow from theory and from the research question. We in the field must rise to the calling for theoretical rigor. If not us, then who? Thank you.
Thank you very much, Dr. Allen. Next, we will hear from Dr. Amuta Onukaga. Over to you. Thank you.
Good morning, everyone. It's a pleasure to be here with you all. Thank you to Dean Galea, thank you to SER, and thank you to the leadership team at SPH. I'm going to talk about epi and race and why we study, how and why we study racial health disparities. So the premise, as Dean Galea mentioned in his opening remarks, looking at racism as a public health crisis, this lens of focusing on the impact of structural racism really was heightened last year during the George Floyd murder. I also want to lift up the name of Breonna Taylor, Ahmaud Arbery, and many others. And so thinking about the impact of racism on public health, we know that structural racism is a system in which public policies, institutional practices, cultural representation, and other norms work in various reinforcing ways to perpetuate racial group inequity. This has a big impact on the health of people of color and other marginalized populations, and identifies dimensions of our history, so the historical context of the way that we look at medicine, the way that we look at data, and the way that this plays out in public health, have allowed privilege associated with whiteness, right? Like even till today, we still use white as the reference group in a lot of our data, in a lot of our studies, and disadvantages associated with color to endure and adapt over time. So these public policies and practices contribute to structural racism by reproducing outcomes that are racially inequitable. And structural racism really is a feature of this socio-economic and political system in which we all exist. And so when you overlay that with health disparities, you overlay that with the impact that racism has on public health, you see that play out in many different health outcomes, as I'll talk about in a minute. There are vast disparities in job opportunities, income, and inherited wealth in families of color over generations. We know that African American families are more likely to have their homes appraised at lower values, specifically 23% lower than their white counterparts, which translates to billions of dollars lost in potential earnings, family wealth, value. We know that people of color are less likely to have housing security and access to quality schools, healthy food, and green spaces. And all of these factors undermine mental and physical well-being. So applying a racial justice lens, a racism lens to looking at indicators. And I chose infant mortality because we all know that in public health, we use infant mortality as a snapshot, an indicator of the health of a nation. And this data show, I did my dissertation on infant mortality, looking at the impact of racial and ethnic disparities by neighborhood level disadvantage over 10 years ago. And the numbers were pretty similar to where they are now. And we know that Black mothers are still twice as likely to experience stillbirth and infant mortality when compared to Hispanic and white mothers. And so I think for me, the way we use data to address health disparities is one, to continue to lift up the opportunities for intervention and how does that play out in research, how does that play out in community engaged work, but two, to also really understand the context that places and continues to place African American infants at higher risk of infant mortality as compared to all other groups. We also see this play out in maternal health, and my current research focuses heavily on addressing maternal health disparities in Black women. And the data that we have, again, shows this disturbing increase in disproportionately African American women being burdened by maternal mortality and also severe maternal morbidity. And so when we think about the premise of our talk today, looking at the way we use epidemiologic research and the focus of racism and addressing health disparities, we have to think about the impact of these disparities and the impact of data on women's health and on the status of women across the country, because it presents an opportunity to take a wider lens into the clinical care, the research, the infrastructure that Black women enter into in pregnancy, postpartum, that place them at increased risk. And how did we get here today? Thinking about it from a historical context. I also wanted to lift up the role of measurement tools. And so this particular one I'm addressing, the VBAC calculator, vaginal birth after cesarean. So it's an algorithm that estimates the likelihood of successful birth after having a prior cesarean section. And this is important because clinicians use this as an estimate to treat patients, counsel people who have decided whether or not they want to try and have a vaginal delivery then rather than undergo another repeat C-section. Why is this significant? Well, we know that cesarean delivery increases the chances of complications, increases postpartum issues around morbidity, and it's a major surgery, right? And so this VBAC calculator uses race and corrects for African American and Hispanic factors and subtracts the estimated success rate for someone that identifies as Black or Hispanic. That's problematic because when the physician looks at that data, they may counsel their patient differently. You know, the VBAC score predicts a lower chance of success if the person is identified as Black or Hispanic. Why is it significant? It's significant because we know that Black women, as I showed you in a previous slide, the data points that Black women are 243% more likely to experience pregnancy-related complications. 63% of maternal deaths are preventable. And we know that there's an increase in maternal mortality as experienced by Black women. So the way that we use data and this race correction is problematic. It's problematic because physicians are going to look at this and they may potentially advise their patients in the interests that are not in their best own interest because of what this score does by race. So in other work, looking at the impact of why does this matter and how do we use data and what is the impact of racism in health. Some recent work that was done by a colleague of mine, Dr. Rachel Hardman at University of Minnesota, looked through hospital birth records, looked at epidemiologic research, and found that for Black newborns who are 3 times as likely to die as white newborns during the study period in the population they looked at, when the doctor of record for Black newborns was primarily a pediatrician or neonatologist or a family practitioner of color or that was Black, the mortality rate was cut in half as compared to whites. And so I think looking at the data provides a real opportunity to address health disparities, to eliminate some of the gaps that we're seeing, and to ultimately save lives. Another thing I just wanted to lift up is looking at the opportunity for addressing implicit bias. I know oftentimes we talk about the role of data and we call it implicit bias or explicit racism. And when you think about implicit bias and explicit racism, we have to think about the source, right? The source really goes back to the training that happens for medical students or public health practitioners. And really the goal is to build equitable communities and to provide practitioners, epidemiologists with tools to help build healthier, more equitable communities and call for an investment to create communities of opportunity for underserved populations. And that's really the premise of what I'm saying is that when we look at the data, we need to be working on using the data for good and using the data to shape and improve health outcomes for everyone. Thank you so much.
Thank you. That was a really fascinating presentation. Now we're going to have Dr. Donna Young talk about his work and his thoughts. Thank you, Dr. Donna Young. Over to you.
Okay. All right. Well, thank you so much, Dr. Serda, for the kind introduction. Good morning, everyone. Thank you to the Boston University and the Society for Epidemiologic Research for this opportunity. It's a great pleasure, honor, and privilege to join the distinguished panel of speakers to contribute my thoughts to this important topic. Has epidemiology made a difference in race-related health disparities? I represent the College of Pharmacy and Public Health at The Ohio State University. However, the opinions expressed here are mine. I have no conflicts of interest. Briefly, I'll introduce my viewpoint, provide the context for my take on the topic of the day, discuss the current state of research, and close with future directions. I reframed the topic to slant it towards my area of interest, the field of pharmacoepidemiology. Briefly, by pharmacoepidemiology, I am referring to the application of epidemiological methods to study drug utilization, adherence to medications, the safety and effectiveness of medications in real-world settings. My take on the topic of the day is guided by the framework for measuring progress in health disparities research. Briefly, there are 4 phases of health disparities research. The first phase focused on documenting the existence of disparities. The second phase focused on documenting the second phase then zoned in on explaining identified disparities. The third phase, which I think we have not concluded yet, is about developing interventions to address disparities based on the evidence accumulated over the years from phases 1 and 2. The fourth is a recently proposed phase that is challenging all of us to think about engaging with disadvantaged groups and racial minorities to solving racial disparities. We are also challenged to move away from the single risk factor research to multi-level determinants research that can inform the development of multi-level interventions. For instance, although studies have shown that several patient, provider, and environmental factors are risk factors of medication non-adherence, there's inadequate data on how these multi-level risk factors act individually and interactively to drive disparities in non-adherence. In the next slides, I'll present a few examples of the research that has been conducted in phase 1 and phase 2 research. Gonzalez and colleagues reported that not only were Blacks less likely to receive pharmacotherapy for depression, they were 59% less likely to receive guideline therapy compared to non-Latino whites. In another example, in this systematic review, Behr et al. Found racial and ethnic disparities in adverse drug events. This table doesn't show the complete picture. What they found were the following. Whites were most likely to experience opioid-related adverse drug events. However, Asians were most likely to experience adverse drug events related to anticoagulants, so mostly bleeding. Blacks were also more likely compared to whites to experience bleeding when treated with anticoagulants. But we saw that Blacks were most at risk for experiencing hypoglycemia associated with the use of anti-diabetic agents. In yet another example, Lewy et al. Found that non-whites were most likely to not adhere to prescribed medications compared to whites. In an example for the phase 2 research, this is our own research. This paper has provisionally been accepted for publication. We found that although Blacks had the lowest adherence to antihypertensives, they were actually more likely to adhere to their medications when they had good communication with their provider and felt involved in making sure decisions about their health. What was striking is that these constructs of patient-provider relationships had no effects on the odds of adherence among other racial groups. So where does pharmacoepidemiology stand in making a difference to race-related disparities? I think that pharmacoepidemiology has made some significant contributions to the first and second phases, but not much to the third and fourth phases. One could argue that because pharmacoepidemiology is largely an observational science, that it is understandable that there hasn't been much work within phases 3 and 4. So where do we go from here? I say to the barbershop. I chose this study by Victor and his colleagues to illustrate how we can develop effective interventions by paying attention to the evidence accumulated from phases 1 and 2. In this randomized controlled trial, the investigators partnered with barbers who acted as health promoters to recruit their clients into the study, which aimed to test a potent and convenient blood pressure control program for Black men. Excuse me, sorry. They set up treatment sites inside the barbershops with trained pharmacists who treated eligible participants. The control group were participants who went to other barbershops that did not have a pharmacist. And here are the results. It's not surprising that the program largely reduced blood pressure among participants who went to barbershops where they had pharmacists. But what I found actually more interesting is that, and I have to caution that these were not the primary outcomes for the study. But what I found interesting is that this program also improved adherence to antihypertensive medications compared to other patients who were receiving care from their usual provider. And also strikingly, the patients who received care through these barbershops actually had better quality of treatment, which was indicated by the use of first-line drugs for antihypertensives compared to patients going to receive care from their usual provider. This statement from this gentleman, a study participant, sums up everything. I'll let you read for a second. Based on his comment, is the barber someone he trusted most that made the most impact on his blood pressure control? This is a great example of taking research to the community after accumulating data that shows that despite the fact that Blacks receive antihypertensives at the same rates and make lifestyle modifications similarly compared to whites, that they continue to experience poor blood pressure control. But just based on making modifications by taking research to the community, engaging with the community, we saw significant improvements in blood pressure control. So I would like to conclude by saying that we have problems to be solved, not to be whole. And some of the areas where I believe pharmacoepidemiology can continue to make impact is the prevention of adverse drug events, especially those emanating from drug-drug interactions, because polypharmacy, the use of multiple medications, is prevalent among racial minorities. And we need to continue to do more work in identifying the multi-level determinants of disparities in medication adherence, and to have a better understanding of how the social determinants of health affect the effectiveness of medications. Thank you. Before I conclude, I would like to make acknowledgements. The slides that I presented were based on research and studies from the following authors. So thank you to all of them. Thank you.
Thank you, Dr. Donna Young, for a fascinating talk. Now we're going to hear from Dr. Graves. Dr. Graves, over to you.
Thank you for inviting me to be part of this esteemed panel. I want to make it very clear to the audience that I'm not an epidemiologist. And I also want to make clear to folks what I actually do. So I study the genomics of adaptation. And I'm trained as an evolutionary geneticist, and I do experimental work across my career in Drosophila melanogaster model, and also now bacteria. And I want to point to the words of Jacques Monod, who said, what's true of E. coli is true of elephants. And in that regard, I apply the evolutionary theories of adaptation to understand health in a variety of species in ways that are relevant to understanding health in humans. So I've written 2 books addressing allowing one to understand biological conceptions of race and how they're disconnect with social conceptions of race. The first book, The Emperor's New Clothes, was published in 2000. First version was published in 2001, and it's the history of racial thinking in the Western world, going back to the ancients. The second book, The Race Myth, Why We Pretend Race Exists in America, is a book that assumes that you understand the history of racial thinking and then goes to speak to the ongoing social pathologies that result from engaging in racial thinking. Both of these books have chapters on health disparity. Now, I hoped I would never have to write another book on this subject again after those, but it turns out that there's still much ongoing confusion about how biological and social conceptions of race interact. And so with my colleague, Alan Goodman, who is a former president of the American Anthropological Association, we completed Race and Racism, Answers to Frequently Asked Questions this summer in 2021. Literally, I was writing the conclusion of that book as the events around the murder of George Floyd unfolded. Now, the goal of the work was to provide concise and relatively simple answers to questions that we'd gleaned from students, educators, policymakers, friends, and family over both of our 30-year careers. The contents that are most relevant to this audience are Chapter 3, Everything You Wanted to Know About Genetics and Race, Chapter 4, Everything You Might Want to Know About Racism, and then Chapter 5, Why Do Races Differ in Disease Incidence, Chapter 6, Life, History, Aging, and Mortality, Chapter 7, Athletics, Bodies, and Abilities, Chapter 8, Race, Brains, and Behaviors, and Chapter 10, DNA and Ancestry Testing. Now, the claim has become a platitude. In other words, race is not a scientific concept. It's widely used by scholars in the humanities and the social sciences. I've been misquoted by the New York Times, the LA Times, saying Graves says that there's no such thing as race. I've never said that. And that is, in fact, absolutely incorrect. Race is a scientific concept. However, the problem is that people continue to conflate two different definitions and understanding of what race is. The biological race concept, which was generated by my field, people who study variation within species, not just humans, and it has developed over the course of the biological sciences from Aristotle to the 20th century. So this concept went from the original morphology, or what organisms look like, to where they were found, geographical location. With the coming of the neo-Darwinian synthesis in the 20th century, it became population-based, looking at the frequency of genes found within populations and between them. And then shortly after that, using phylogenetic techniques, by determining whether any group can be considered a unique evolutionary lineage. Now, this is dramatically different from the subject that occupies epidemiology, which I call the socially constructed or socially defined race concept. This arbitrarily utilizes aspects of morphology, geography, culture, language, religion, anything that you want to throw in the blender, but always in the service of a social dominance hierarchy. So Alan and I say in our new book that racism created race. In other words, for human beings, there was a necessity to create a system to justify the behavior and treatment of various individuals in existing social dominance hierarchies. So when I looked for, how epidemiologists treat this question, I went to a commonly used undergraduate epidemiology text, and Merrill says race is a socially constructed variable based on the idea that some human populations are distinct from others according to external physical characteristics or places of origin. Now, this is the same as my socially defined race concept, but it is not the biological race concept. Now, I want to make it really clear for those who are not familiar with my work. Our species, anatomically modern humans, does not have biological races. Now, how could I say that if there weren't species that did have biological races? And it turns out that there are a lot of large-bodied mammals that do have genetic differentiation that is equivalent to what modern evolutionary thinkers like myself would call biological races. But our species does not. And that is why I wrote The Race Myth, why we pretend race exists in America, because the argument for the existence of biological races in modern humans is entirely specious. So Merrill continued, racial or ethnic variations in health-related states or events are explained primarily by exposure or vulnerability to behavioral, psychosocial, material, environmental risk factors and resources. Now, that actually is not an entirely adequate understanding of the issue. And that in part comes from a confusion about the nature of the genetic causation of health. And this is also made worse by the use of categories to define groups of human beings that really have little to no support in the biological variation of our species. So these terms, white, black, American Indian, Asian, Hawaiian, Pacific Island, these are all political delineations that really are not driven by the nature of the underlying biological variation within our species. The notion that you create one ethnicity that speaks Spanish and one that does not is even further example of the lunacy of this classification system. Now, what we actually know and what we can really lay, our hands on with regard to the nature of human biological or genetic variation in this case, is that surprisingly, there has been very little adaptation in our species. And that's in part because we are a young species, only about 300,000 years old. And for the most of our time, we existed in a limited region of sub-Saharan Africa for 200,000 years. So the amount of adaptation that occurred in human beings as a species really dates to the last 100,000 years. And some of these adaptations are as young as 10,000 years ago. Things like, for example, blonde hair or blue eyes are less than 10,000 years old. And what's even more revealing is that when we look at the examples of traits for which we really have evidence of adaptation for, most of these things are single gene Mendelian traits. The business of health disparity is actually in polygenic traits for conditions like heart disease or cancer or stroke or COPD or emphysema. I could go on and on and on. Most of these conditions are polygenic traits, okay, but not the result of the action of single Mendelian alleles. In fact, the only example we have of a polygenic trait showing strong evidence of adaptation is for height. And again, this is only in a couple of places. So we have evidence for selection favoring greater height in Northern Europe, and we have evidence for what's called the rainforest phenotype favoring shorter height in Central Africa and in South America, in the rainforest. But for the most part, we have absolutely no evidence supporting adaptation occurring on polygenic traits. Now, to give you an idea of how misleading these social conventions can be with regard to ancestry, I here show examples of people who are defined as Hispanic by our classification systems and what their ancestry looks like. So if you look at people defined as Puerto Rican, they have a much higher percentage of African ancestry, about 12%, compared to people who are called Mexican American, who have an ancestry, African ancestry of only about 3%. Now, this has to do very much with the history of chattel slavery. So if we go to Colombia and we look at two neighboring states, Medellin and Choco, and look at the difference in the tripartite admixture of African, European, and Amerindian genetic ancestry, they're dramatically different. In Medellin, there was very little chattel slavery, but in Choco, there was much chattel slavery. And so when you look at the genomic background of these two groups, they're Colombians, they're defined as Hispanic, but their genomic ancestry is very, very different. Now, quickly, disease risk results from three factors: genes, simple Mendelian versus quantitative. So if someone makes the claim that, simple Mendelian genes can't be a factor in health disparity, that's just wrong. I gave you a really good example. For severe combined immune deficiency, the frequency of those carrying this trait is 1 in a million, calculated on the world population. For people of the Navajo and Carilla Apache nations, it's 1 in 2,000. Now, severe combined immune deficiency is a terrible disease. There's clearly a disparity. Now, it's not the fault of the Navajo or the Carilla Apache that they have these elevated rates of the severe combined immune deficiency mutations. It's the result of being placed on reservations during the conquest of the American territory by European populations. The resulting mortality in these groups led them to having less than 600 members after the wars against these people were concluded. So genes do contribute to disease risk and do contribute to disparity. However, the way this happens is different depending upon whether it's a Mendelian or a quantitative trait. The other factors are environment, and also chance plays a major role. So the equation that allows us to understand the variation that we see in any phenotypic or physical trait, including disease, is given on this last to the next to last line, where that comes from variation due to genetic sources, which now includes epigenetic changes, which I honestly don't have time to discuss today in 8 minutes, plus environmental factors, plus gene by environment. But most insidiously, this term, which relates to the covariance of genes and environment, in which genes can vary with environment either positively, meaning best genetics in best environment, or they can be negative, meaning best genetics in worse environment. So either way, you can come to a false determination of a genetic contribution to a phenotype without understanding the reality of the covariance of genes and environment term. In addition, the error in which you measure the phenotype can be quite substantial, particularly for medically relevant traits. Take, for example, how physicians are more likely to diagnose an African-American patient with schizophrenia just when they display the same symptoms as a European-American patient suffering from bipolar disorder. And so error is not an insignificant term, particularly when we talk about the history of implicit bias and racism in American medicine. Now, we can understand the contribution of the genetic effect on a disease by the heritability equation. And I quickly want to show you that when we utilize this equation to look at a trait like lifespan or longevity, that in the 20th century, European Americans had some of the highest genetic components to their lifespan. Now, heritability of 0.3 is actually very high as has ever been measured for this trait. And what that means for persons of European descent, their genetic composition more so determined their life, possibility of life, than for Caribbean Hispanics and African Americans in the United States. In other words, the detriment that these people displayed in terms of their lifespan was more due to the environments in which they lived in. Now, I summarize a whole bunch of studies below that show that when you move people of African descent from countries where they are the majority to countries where they are in the minority and then racially subordinated, that their health drops off the table. So this, again, is not saying that there's something inherently wrong with the genome of African descended people. What it's saying is that those genomes face racial subordination, and those racial subordination has impact on their disease profile and health. Now, to sort of bring this point home, when we look across the entire genome for these complex traits, because all of the genome contributes to them, and I can show you this, again, I don't have time to demonstrate this today, but I do experiments where I do genome-wide association on life history traits, and the entire genome of the organism contributes to them. So what we want to know is, what does the genome look like in African Americans and European Americans relative to whether they have, quote, good or bad genes? So if we look at genes that are possibly deleterious, then there's no statistical significant difference between African Americans and European Americans. But if we look at genes that are probably deleterious, we can show that people of European descent actually have more probably deleterious genes than African Americans display, which means if genomics alone were determining the health profile, we would expect the health disparities that we observe in people in the United States to be flipped. In other words, people of European descent should be showing more disease, and people of African descent should be showing less disease, but we see the exact opposite pattern. Now, finally, I'll end with, how could we actually determine the degree to which the genome is contributing to a health profile? To do that, you would have to do a classical transplant experiment in which you would take one group, in this case, African Americans, and transplant them into the environment experienced by European Americans. And then you would have to transplant the European Americans into the environment experienced by the African Americans. Now, any health attribute that stayed the same after these transplants probably has a very strong genomic component. Now, what I would argue, and I'm sure you all agree, such an experiment is ethically and morally wrong. But what we could do is we could eliminate the racial subordination of African Americans. And what I would argue is if that were done, their health profiles would improve. And most of the things that people are trying to claim are the result of genomic differences and what I call the myth of the genetically sick African, okay, would be shown to be the result of the racial subordination which people of African descent have suffered in this country for the last 400 years. So for those who would like to read more about my thinking on this question, I've included some references, and I will stop here.
That was really fantastic and very thought-provoking. Thank you, Dr. Graves. Our last presentation today will be by Dr. Ocampo. Thanks, Dr. Ocampo.
Thank you. And I'd like to thank BU and SER for hosting this series of panel discussions on this important topic that has the potential to inform solutions to the racial disparities that we see all across North America. It's certainly hard to be the last speaker, especially with this distinguished panel, as all the key ideas have already been mentioned. And I, of course, support the messages of the panelists, both today and yesterday, and that they've shared so far. And I hope that my comments build on those and expand a few of those points. Sorry, I can't do my technology and talk at the same time. So I'd like to share with you a small celebration of the 10-year anniversary of the publication of our book, calling on social epidemiologists to adopt a bold stance to move our field forward toward a science that intentionally informs and supports societal change. We're great at describing problems and demonstrating associations, but less so in using evidence to design interventions. Certainly one way to do that is for us to go further upstream, as that's where the root causes are for so many of the health issues that epidemiologists tackle. And the good news is that we've seen many more studies focusing on systemic sources of oppression experienced by people of color, including systemic racism. But we could go further to create an even greater balance between studies focusing on structural determinants versus those focusing on individual and interpersonal experiences of discrimination. The authors also call for epidemiology to get involved in the messiness but critically important activity of generating evidence to design and evaluate solutions to the social determinants of health and structural racism. The task for that, the pace for that task has been too slow to date, but it's not too late for us to turn our focus toward this growing area of research. The chapter on race in the book, called Differences That Matter, urged epidemiologists to avoid kind of routine demonstration of outcomes by race, just to demonstrate yet another gap. It tends to be a habit. It's interesting, after relocating to Canada, where we don't have access to routinely collected data on race, you get a whole different perspective on that particular practice, and wonder how useful that is in helping us to really solve this problem. We need to be mindful of the unintentional consequences of doing that poorly, that is, without rich data on the context for the disparities and about the disparities, as we risk reinforcing the false racial hierarchy that's so prevalent in our society that brings harms to so many communities. Instead, and as emphasized by the panelists already, we need to contextualize the research questions, draw on very strong, rich theory when we interpret our findings and make sure that we're also consulting history to get at the why those disparities exist. To do that, the panelists have already emphasized the need for even more data related to why we see differences on race, better data on racism, and also other types of exploitation or domination or oppression that individuals might experience due to their membership in groups that have historically been marginalized. As a field, I think we're doing better, but again, we could pick up the pace on the unanswered questions, which some of the panelists have already talked about, and the panelists later this afternoon will address. But on that point of understanding a person's multiple oppressions, I do want to call attention to a practice in epidemiology that may be concerning. When we do that, a term that is being increasingly used is intersectionality. So intersectionality in epidemiology is increasingly being presented as the concept where all the identities and the membership in groups that are traditionally marginalized be identified so that we can understand how those multiple intersecting identities affect well-being. And certainly this is an important concept. And if we're trying to understand oppression, then we should be working harder to capture the sources of, again, exploitation and domination experienced by the populations that we're studying. There are many groups that remain hidden, resulting in too little evidence for those groups in terms of how they experience marginalization. I'll just call one out. For many years, we didn't study Native populations, indigenous populations very much because too often our numbers were small, or we just lumped them into the majority group. And so we didn't have enough evidence on that population. And that's happening with other populations who are experiencing marginalization. And I certainly fully support this, that we should do more of this. However, this is not intersectionality. If you read the literature from other disciplines and read widely on the topic of intersectionality, you'll see that it is a contested term with very good reason. Here too, building on the recommendations from the panelists yesterday, we need to understand our history. Intersectionality emerged over 50 years ago from a desire to achieve racial justice. Intersectionality is about transformative change for people of color and Black women in particular. As intersectionality was born of the realization that neither feminism of the time or Black liberation movements at the time would liberate Black women. Intersectionality is not a tool just to document multiple membership into groups experiencing marginalization. And it's not merely a theory of difference between individuals. Intersectionality recognizes the structural oppressions that marginalize people of color, women of color in particular, and Black women in particular, and how those multiple oppressions converge to create kind of a new kind of suffering that seeks to center Black women's struggle for transformation and emancipation from structural oppression. So concerningly, in our current usage of the term intersectionality in many academic circles, including epidemiology, we are again erasing the plight of women of color. We in epidemiology don't want to be the scientists that appropriate ideas from people of color and change them to make them our own. This would be reproducing the original conditions which birthed the idea of intersectionality. And we don't want to be accused of practicing a colonized science. At the same time, intersectionality represents important concepts that we do want to capture in our epidemiologic studies on race. All right, so what should we do? We should be using intersectionality because it helps us not only understand structural racism, but we need to use it in its original form given its focus on challenging structural oppression. So when we use intersectionality, we must honor its history. We need to center the experiences of women of color and Black women in particular. And we need to see it as a critique of structural racism and to use it to transform our structural oppressions. Now, we should be capturing more information for our study populations about their full experiences of marginalization. So I'm not disagreeing with that activity. We absolutely should, but if it doesn't do those things that I mentioned, we should not call it intersectionality. So when we do look at multiple oppressions, we need to be sure that we're doing so at multiple levels. And again, this has already been mentioned. Our EPI study should be capturing the full range of discrimination and oppression that create racial disparities. And here are some key aspects of discrimination and oppression to consider measuring. You know, at the individual level, we do a lot of research on looking at exposure to discrimination of different types, including racial discrimination. We do a little bit less on looking at the interpersonal interactions. After all, racism is a relational idea. There is somebody who is doing the discrimination and somebody who's the recipient. So somebody is benefiting from discrimination and somebody is being harmed by it. So we need to do more to look at the interactions between people, the information in the middle. And that'll enable us to focus more on those who benefit from discrimination. We're actually often very silent in our studies on white populations who often are the beneficiaries of discrimination, whether they're doing the discriminating or not. We need to understand that better. We're certainly seeing excellent studies emerge to capture the systemic oppressions. For example, there's studies capturing historical examples of structural racism on residential segregation, Jim Crow, redlining, and more. And we need to make sure we're also capturing more of that structural oppression that's happening right now. As I would argue, we really need to design solutions to dismantle racial oppression. And we also need to focus on the component of structural racism that is often a bit of a silent partner, and that's white supremacy. Perhaps it's silent because we rarely include it in our models. We often focus on racism itself, but it is a very strong partner as it actually anchors systemic racism and acts as a barrier to the efforts that we try and put in place to undo it, undo systemic and individual racism. So white supremacy is not meant to represent, ideas of far right-wing individuals or bigotry. Well, it does include that, but it's not only that. We can think of it, in the words of Barbara Smith, as a universal operating system that relies on entrenched patterns and practices to consistently disadvantage people of color and privileged whites. And it's always been with us. She calls it a rigid nexus of power that protects and enforces structural racism. And so we need to name it so we can understand it and change it. Often when we are creating interventions to address racism, so we have trainings and educations that we're targeting certain groups in workplaces and universities, et cetera, those will not be effective until we actually deal with white supremacy. So the last point I want to make is perhaps the amount of research that we do on this area. We certainly have a lot of research that's happening on individual racism, experiences of discrimination. We have less information and fewer studies as we move upstream toward systemic racism. So we need more studies on that. So instead of having more studies on individual, an ideal would be to have more studies looking at systemic racism and white supremacy and their role in maintaining and generating racial disparities. And, if we've learned nothing else from COVID, I think we've learned that we can actually make changes fast. I think many of us have pivoted to doing COVID research, and we've developed the vaccine quite rapidly. So I would urge us to hurry the pace of making sure that we generate information to address systemic barriers to racial equity, and to generate information that will help us design strong solutions. Thank you.
Thank you, Dr. Ocampo, for a very interesting presentation. And thank you to all of our speakers for really just a wonderful discussion of how we can use data to reduce rather than exacerbate racial ethnic disparities in health. I think in the interest of time, we're going to go straight to the questions from the audience. I know we have a lot of participants and a lot of questions have been coming in through the chat. So let me go straight there now. Starting off with Marie Mueller, who asks, do you think it's necessary to go back from the population level to the individual level, that is the lived experience of the individual, to be able to take into account the many factors that impact on health? There's so much variance in lived experience within groups.
I can start, and then I think that this is relevant to the talks that everyone gave, but in particular to the comments that Dr. Ocampo just mentioned. I mean, I would say that it's not one or the other, that we need all levels. We need to interrogate all levels. I do agree, however, that really understanding in depth lived experience at the individual level is incredibly important. And perhaps more importantly, we can't capture that with the 5-point Likert scale. So I think that there is an important role for qualitative research to play in really understanding the depth of these experiences. One, it can inform the development of measures that we can use in our quantitative studies. But, I have, heard people say that you can't really assess intersectionality or really understand lived experience if you're only using quantitative data. And I think that the lack of, and maybe the prescriptive way that we think about methods in epidemiology has prevented us from using methods from other disciplines that can really enrich the questions we ask and our understanding about what's driving some of these health disparities. So I would argue that we need to really pay attention across multiple levels. And to Dr. Ocampo's point, this issue of intersectionality, I think, is a very important one and does speak to this issue of lived experience. And so I'm a very staunch proponent of within group studies for that reason, because we tend to want to kind of make these binary comparisons all the time, comparing whites to blacks, old to young, et cetera. We can think about all these different binary comparisons. And when we do that, we limit each group to their average and don't explore the tremendous heterogeneity within groups. So again, I'm a staunch advocate for within group studies. I do a lot of work among Black women so that I can actually explore the richness of that heterogeneity. And I'll also say that from the perspective of white supremacy, going back to Dr. Ocampo's point, is that, again, this is structural, and it's not just about the structures in society, it's the structures of our discipline. It's the structures of the scientific enterprise. So as one example, I have received comments on more than one grant proposal from grant reviewers saying, where's your white comparison group? And they see that as a fatal flaw. And then the studies don't get funded. So when are we going to actually change the way we think about the kind of research that is actually worthy of funding, that's worthy of investigation? This is on us to actually change the way that our science governs what counts as research.
Thank you. Would anyone else like to comment on this issue? Okay, so I think there have been some questions coming up, several questions around the issue of action. That is the frustration with work that keeps documenting disparities that we already know exist. So the question is, if we already know inequities exist, is our time and energy not better spent addressing what we know to be true rather than proving what we know to be true with more data? So how, and I think this is an issue that comes up a lot in epidemiology, but so how can we move beyond that cycle? And as it seems to be an impediment to real action. And so how can we use this to actually address racism?
I can start. Oh, no, go ahead. Did you want to say something?
You can go ahead, Dr. Akram.
Okay, all right.
I'll follow afterwards. Yes.
All right. So I think it builds on what Dr. Allen was saying, in that we need to diversify the acceptable methods that we use in epidemiology and social epidemiology. The whole area of designing and implementing and evaluating solutions is quite different than the epidemiology methods that we're often trained in. And so we need to do something about our training. We need to value the use of evidence and epidemiologic evidence in designing and evaluating solutions. And something that was said yesterday is working with communities to really get the context right so that we can design interventions that are relevant for the populations that we care about. So partnering with communities who are affected is a critically important step in helping us to get closer to designing good interventions.
I completely agree. I think you said almost all that I was going to say. And as I showed in my presentation, you know, we are at the fourth phase of fourth generation of disparities research, whereby we should be engaging more with the community and developing multi-level interventions that go beyond just addressing individual or single risk factors. You know, with epidemiology, because most of us, this is an observational field, there is still an opportunity for us to also begin to design our studies and apply methods that are able to produce data that are more actionable to drive and guide the types of interventions that we require in the community. And that's why I use the barbershop as an example, because we accumulated this data. We knew that blood pressure control was a big challenge within Black communities, despite all the efforts. You know, the data from the trials show that antihypertensives were effective among Blacks in the trial, but when you go to the real world, we never saw that translate. And it was just, you know, partnering with barbers and getting the, you know, care into the community that really seems to be shifting the needle. Of course, there is accumulating data to show that it's effective, but that's the type of research that we should be doing to guide interventions.
If I could get a word in edgewise, I mean, I all on the side is we already know what the issues are. Okay, so it comes down to a question of how do we, as intellectuals, who many of whom are from the communities that are racially subordinated in the United States, how do we stimulate political action to change the structures which are killing our people? And that is really what it comes down to. And I happen to be at a historically Black university. I think I'm the only person on this panel that's at a historically Black university. So, you know, our land grant mission isn't the land grant mission that North Carolina State has. Okay, our mission is primarily to serve the interests of people of African descent in North Carolina. Now, I won't say that we do it perfectly, and I certainly have all sorts of issues with some of the things that we do, but this really comes down to a question of political power. and as people said, naming white supremacy. The United States is a white supremacist nation. It's allied with white supremacist forces all over the globe. And unless we're willing to say these things clearly and demonstrate how white supremacy is differentially killing people who aren't white and making that the issue at center stage in this moment, then we've failed, what we've been charged to do. We've failed our community. Now, you'll note that in my writings, I do that all the time.
So talking about action and about political action and accountability, I think it relates to one of the questions that have been raised by another participant about occupational segregation, and so the role of businesses, right, and in promoting health disparities. And so what this person says is there's been a reluctance to look at occupational segregation and the adverse effects of certain jobs as a contributor to disparate health outcomes for people of color. So what are your thoughts on that, on looking at that, on the role of epidemiology and the broader fields represented here in addressing that, and more broadly in bringing businesses, making businesses accountable to change those issues?
I'll just jump in. Oh, Joseph, did you want to jump in?
No, I want to let you talk first. I don't know that people want to hear what I'm about to say.
Oh, we do. So I'll be brief. I think economic exploitation is really critical for us to be measuring more explicitly in our research. There's all kinds of economic exploitation that happens at the job. If you have a tenured position, you do experience some exploitation depending on your social location, but not as much as somebody who's going to be a gig worker, for example, who's delivering food during the COVID pandemic. And we know that economic exploitation is differentially distributed across populations, and I bet we can guess what that distribution looks like. So, and I think businesses have an interest in that exploitation because they can maximize their profit. So we need to be more explicit about that theory of oppression as well.
So I'm going to go further, and again, capitalism and racism were tied together at the hip from the very beginning. It is hopelessly naive to think that in the 21st century, you're suddenly going to get people who've operated off the exploitation and appropriation of the labor of Black and brown bodies to suddenly come to Jesus and realize what they've been doing is wrong. That's just not going to happen. And so again, it comes down to us defining for ourselves what we want our future to be. And I have argued again, and you'll see it all throughout my writings, that we have to dismantle this system. So thinking that we can, convince, Wall Street and Madison Avenue that they should change their way of doing things when it's worked so well for them for all this time, that's ridiculous. So we have to be willing to speak to truth to power. We have to be willing to stand up and say, we're going to form our own organizations, and we're going to advance a different agenda, one that's based upon human beings and the well-being of our planet. Because we're at that existential moment, folks. If COVID 2019 didn't teach you anything, the next pandemics that are coming are going to be far worse.
So that actually brings me to another question raised by a panelist about exactly about COVID. So I think everything that you guys have been saying really brings COVID is the reflection of all of these issues. And so this person is struck by the number of scientific papers documenting COVID outcomes and differences by race, but not articulating a clear question about racism as it relates to differences in COVID outcomes. And so the question is, how can we build better partnerships with clinical audiences, with clinical investigators, so that questions about racism as they relate to COVID and as they relate to other emerging pandemics can be better articulated. That seems like a very practical way to move forward in terms of the impact that we can have.
I'm going to quickly say something and let other panelists get in. The notion that COVID 2019 would be or somehow biologically disproportionate by population is sheer utter nonsense. It's a novel pathogen that had never been seen in the human population before. So there would have been no capacity for any population to have accumulated genes that would have protected them from COVID 2019. In the GWAS studies that have been done on COVID 2019, the only thing we know is that greater susceptibility and worse outcomes actually comes from a gene that was inherited from Neanderthals in Europeans. And so once again, when we look at the genomic foundation of disease, we come to the conclusion that people of European descent are more likely to have worse outcomes than everybody else in the world. But yet we're seeing in real world, practice that is, again, Black and brown bodies that are having the worst outcomes. And a lot of that, you all know, have to do with questions of exposure, inability not to go to work because if you don't have a paycheck, you have to, and stuff like that. So that's just ridiculous.
And I think that was the intent of the participant as well, to ask how can we better articulate questions right about the social determinants of these racial differences in COVID outcomes.
Yeah, and I would just add that, we can talk about COVID, but really what we saw with COVID was no surprise. Many of us imagined that this is exactly what we would see because it's the exact same pattern that we see with almost every other outcome, health outcome, and with every catastrophe, natural catastrophe that we see when we look at Katrina, when we look at climate change, when we look at H1N1. It's the exact same pattern over and over again. So at a certain point, we have to wonder kind of what's the least common denominator, right? It's not genes at all. And I think that we have to really start to look at that and collaborate and partner, not only with clinics and physician researcher scholars, but with policymakers and nonprofit organizations, right? Science has never been the measure to instigate action, never. Right, the 99% movement came out, and there had been years and years and years of research on income inequality already. Science was not the instigator to that. And there have been years and years and years of research on racial health disparities. That didn't start with what we're seeing today in this society. And it's not to say that we don't need science, but let's not fool ourselves into believing that the work that we do is going to be what makes change. So we must, it is imperative that we partner with others. And I think it's connected to a very important question about our role as epidemiologists to advocate for change. And this is an age-old debate in the field where this kind of staunch belief in strong objectivity prevents us from actually advocating for policies that we know matter. And as much as I can appreciate our quest for the perfect causal model, let's not let kind of perfect be the evil of good. We don't need the perfect causal model in order to know that it's time to act, because those causal models are not going to tell us anything more about the fact that that Black Americans suffer disproportionately more than other groups, that all Black and browns suffer disproportionately more than other groups. And so we know that, and we also know what levers we can push and pull to start to make changes.
I think that's the perfect ending to this session. Really a call to action and a call for all of us to be able to use what we do, to use science, to use data, to establish partnerships with stakeholders to actually create change and improve conditions. Thank you to all of the panelists for really just such thought-provoking presentations. Before closing, I'm going to pass it back to Dr. Galea.
What a what a privilege to learn from all of you. Thank you. Thank you for really, really terrific presentations and fascinating conversation. If we're together, we would now be breaking for lunch and reconvening in an hour. I'm going to save my comments for after our third panel. So again, I want to say thank you to Professor Serda for moderating. Thank you to all the speakers and thank you to all the participants. We will resume with part 3 in an hour at 12:30 Eastern.